Before we jump into this episode, I want to remind you that while Caitlin and Sophia are dietitians, we're not your dietitians. This means the information shared in the Food Freedom Fertility podcast is intended to entertain, educate, and inform. It is not a substitute for medical care. This information is not intended to diagnose, manage, or treat disease. Always consult with your doctor before making any changes.
Welcome to another episode of Food Freedom and Fertility. I am your host, Sophia Pavia, and Caitlin is out for today, but you've got me, registered dietitian nutritionist, specializing in women's fertility with a special emphasis in helping you make enough progesterone so that you can get pregnant, stay pregnant, and bring home that healthy baby. And I am joined here today by a very rare sight. As listeners, if you've been listening to this for any length of time, you know it's kind of rare that we have a dude on our show. But here he is. We have Dr. Valenson, who is an interventional radiologist, and he works at Houston Fibroid. Very near and dear to my heart because I am a fellow fibroid haver. And I know a lot of you listeners maybe have been diagnosed with fibroids, maybe have had a myomectomy, maybe told you need a myomectomy, maybe all kinds of things, or you're not quite sure what's going on, but you know that you're not pregnant when you thought you would be, and you're just looking for some answers. So we are joined here by Dr. Valenson, who is going to talk with us today about fibroid management and just some other sort of like vascular things that can go on in the uterus that make it difficult to become pregnant and possible treatments. That's really what we're excited about today is in this day and age, uterine fibroids are treatable. Praise God. So thank you, Dr. Valenson, for joining us here. Would you mind telling our audience just a little bit about yourself and your expertise and why we should be so happy that you're here?
Well, thank you very much. First off, I'm very happy to be here. I have had a chance to familiarize myself with the podcast, has some great content, so it's a privilege and an honor. My name is AJ Valenson, and I'm a vascular interventional radiologist. So I realized that's kind of a mouthful. A few years ago, it was pointed out to me that that is the least known field of medicine, which kind of surprised me. But I think it's a field that's growing in popularity. It's where we use image guidance to perform procedures that used to be done surgically. This is to transition healthcare towards a less invasive kind of outset. And our field, I feel, is very innovative and invents a lot of these forward-thinking procedures that eventually many surgeons themselves adapt. So I work in Houston, and our organization is called Houston Fibroids. It's kind of one subset of the many different types of procedures we do. And I think we were one of the first practices in the Houston area to really focus on the outpatient management of fibroids, primarily through our preferred treatment of uterine artery embolization. And we're able to perform these procedures for women in an outpatient setting, often in less than an hour. And typically patients can go home about an hour, hour and a half later, which is kind of a big game changer with this type of procedure. When I was in training many years ago, it used to be very common that these procedures would take often several hours. We'd have to admit the patients overnight, put them on a PCA pump, bunch of medications that might kind of slow down their bowel system, et cetera. And, they might not get discharged for a couple of days or so. So things have changed a lot. And I've been very fortunate to be kind of on the trend-setting edge of this treatment modality.
Yeah, so I am so happy to have you here. Listeners, if you have been following my story, then you already know this. If you haven't, I'll give you my little elevator pitch about why I'm so pumped to have somebody who specializes in uterine fibroids on here. So I actually got diagnosed with a uterine fibroid when I was 12 years old. Maybe I was 13 by that point, but very young. So basically I had painful periods, acne, things like this from the beginning of my cycle. And this was back in like 2001 when birth control pills were all the rage. And so my pediatrician put me on orthotricycline. And so I started taking that and I bled for like 40 days solid. And
Hmm.
so then I was like, well, this isn't normal. So I went in and had a ultrasound. And that's either when, I don't know if it's sort of a chicken or the egg scenario. Did taking this exogenous hormone cause the fibroid to develop? Was the fibroid already there? And that's why I'm having all this extra bleeding. We don't really know. But at that point, I was diagnosed with a fibroid, which I was like, well, what does that mean? And the doctor and the sonographer said, it means you're female. These things, they just happen. They're, sort of, she described it almost as like a variation on normal, that it's really nothing that needs to be treated or worried about or even thought of again. And so, okay, fine with me. She said it was about the size of a grape, and that it was inside the muscle wall of the uterus. So she was like, this isn't it's not like blocking the vagina or like blocking a tube, or like there's something called percongulated, which is like where it's like hanging off the side and it can, have torsion, twist, and cause problems or get wrapped around other organs. Like it didn't, she was like, this is not a problem. So I honestly did not think of it again until I was getting ready to get married, and I was having so much pelvic pain, indescribably, like not indescribable, but like inexplicable. Why is this here? I don't know. And so I just paid a private sonographer to be like, can you just look and see what's going on in here? And this dear man found a ovarian cyst the size of a baseball. It was huge. But the fibroid was still, chilling, not doing anything. But he's like, oh yeah, there's a fibroid here. I don't think that's the culprit, but this big old cyst, this'll do you. So I got to walk down the aisle at my wedding with a giant uterine or a ovarian cyst. So that was fun. But that resolved on its own. And it ended up being, not an issue. But that was the first look I had again at this fibroid. Fast forward to my first pregnancy, the fibroid had gotten enormous, unbeknownst to me, and had started something called red degeneration, which I am sure Dr. Valenson has heard about. Basically, my fibroid outgrew its blood supply and started dying. And this caused my uterus to contract extremely painfully. And as someone who had never had a baby or a labor before, I thought this must be labor or something like that. Go to the hospital. They treat me terribly. They hate me because I was planning a home birth. I stupidly told them that I was planning a home birth when they asked me who my OB was. Don't make that mistake.
Don't do that.
So they were like, oh, you think you're too good for us? Well, we hate you. No, basically they said there's nothing we can do. Like, you either go home and your baby will fall out early. I was like 20 weeks along at that point, and they were like, your baby's just going to come out and die. So we can give you Pitocin and speed this along and speed up her passing. Or we can do nothing and send you home. And I was like, oh, well, I don't want to just kind of deal with her. So I am going to pass on that. And then my midwives thankfully were like, what? Those people sound crazy. That's not what's going on at all. It's probably this massive fibroid. So I went and had it imaged, and it had grown to 11 centimeters. It had gotten, it's a big one. It's like as big as my large baby. So that happened. Thankfully, I kept the pregnancy. I had my healthy baby. Everything was great. There was a little bit of an issue after I had her because the placenta had detached, but the membranes around, like your bag of waters that the baby's in, they had broken sort of near the fibroid in the way that anyway, so there were some trailing membranes, basically. I'm saying this to Dr. Valenson so he understands this as well. But so it made it a little harder. It wasn't technically a retained placenta because the placenta had detached. It just was that it wasn't coming out. So we had to do a little body work and things to get it out. And then in my second birth, there unfortunately was a bit of a hemorrhage, and it wasn't able to be managed as quickly because when you have this big old fibroid, the way your uterus will clamp down and stop bleeding once the placenta detaches, it's a little impaired.
Yeah,
And
can be
so
disrupted. Right.
it was disrupted. And it
Hmm.
wasn't anyone's fault except for the fact that I was in a bad position when I pushed my baby out, and her cord was so short that it actually detached the placenta and started bleeding horribly right then.
So
So if
the
I'd been
cord pulled the placenta with it, basically,
it
and
did.
detached
It
it.
pulled the
Wow.
placenta away from the
Yeah.
uterine wall. She was, yeah, it was the shortest cord. My midwife had been to like 800 births, and she said this was by far the shortest cord she'd ever seen.
Wow.
And so it was wild.
And
And
it's hard to predict it's going to do that, right? Like, who would think that?
who
It's
would think
that.
that? You
Yeah,
can't
it's not
really
common.
see a cord
Hmm.
that well on an ultrasound anyway. I mean, you can
And
look
we're
for
not in the
like
habit of
loops.
reporting how long it is, right? That's not really, it's hard to
No,
estimate
and I
exactly.
didn't
Yeah.
think to ask. And I also I went to my like 20-week scan, and I don't think I did anything beyond. I don't think I went to another one after that. So a cord at 20 weeks can look good, but if it's still that length at 40 weeks, well, it's not so good now. But
Right.
anyway, the fibroid made that a little more complicated. But
Hmm.
thankfully, we've had other episodes about blood volume and things like that because I had, dietitian here. I had good nutrition and I had maintained a lot of muscle mass throughout the pregnancy. I did not go into shock, and I did not need a transfusion or to be transferred to the hospital.
Yeah.
I will tell you,
God
I did
bless. Good
not
for
feel
you.
good, but I didn't need any of those things, thankfully.
Yeah. Well, you made it, and you had a healthy baby.
Amen. And so, fast forward to me getting a endometriosis diagnosis about 2 years ago, having an excision surgery, and my doctor being like, "Well, while I'm in there, let's zap this fibroid." And so she did
Mm.
a radio frequency embolization. And we had high hopes that the fibroid would just shrink away after such. It didn't. It didn't change size. It stayed large and in charge. However, I am now 34 weeks pregnant and can happily report that it is the same size as it was before my pregnancy. So something
Hmm.
worked. It did not grow to 11 centimeters and cause
Okay. There you
problems
go.
this time around. It stayed at about 3.5. And here we are moving forward. So that is Sophia's fibroid story for Dr.
Wow.
Valenson to
Wow.
hear, as well as you, the audience. And so it's part of why I'm like, okay, let's hear about
Hmm.
these options. Because I'll tell you, the ladies that I've worked with,
Hmm.
they are basically told you can have a myomectomy. And a myomectomy
Hmm.
is, Dr. Valenson, will you explain what that is?
Yeah, so a myomectomy is a way to surgically target and remove a fibroid and the fibroid only, as opposed to just removing the entire uterus, which is called a hysterectomy. Hysterectomy used to be the go-to procedure for fibroids, and they would just, without thinking about it too much, go in there and just remove the entire uterus. In fact, even today, 40% of all hysterectomies are performed for fibroids, which kind of still shocks me just to even
It
come
is
across that
shocking,
fact.
especially when it's like we're talking about some young, healthy women here. A lot of times, I part
Yeah.
of me is like, I realize our uterus is a vital organ and probably does more than we realize, and so
Hmm.
removing it just for convenience sake is not a good idea. But I also think about the gals like me. I was 12 years old when they diagnosed me with this. You wouldn't
Hmm.
do a hysterectomy to a 12-year-old, completely
Oh God, no.
sterilize her for
No.
life. That's no, we wouldn't
Right.
want to do that. So having a hysterectomy for fibroids just sounds like it should be so the last case scenario, like
Yeah.
a
No.
common choice between her life, her very life,
Hmm.
and this surgery. And so then we'll choose the surgery if it means it's going to save her life. But otherwise, we got to have some options.
Yeah, I agree with you 100%, especially from the perspective of what we do, where we're usually treating women that are looking to avoid surgery. And your story really touched upon a lot of uh, interesting aspects of just fibroids and the life cycle of fibroids itself. But on the subject of hysterectomy, in my opinion, it really should be kind of a last resort. There's the short-term results of hysterectomy generally have been pretty good in that it
Hmm.
is going to cure your fibroid or your adenomyosis or other things, but it's the long-term implications of it that are really concerning. So it's the long-term morbidity of it. And I'm not talking about side effects, scarring, adhesions, or things like that, but just what are the actual effects of removing a woman's uterus, either with sparing or not sparing the ovaries. It has some hormonal implications, and just long term all cause morbidity and mortality is worse in patients that have hysterectomy compared to not. It's known to affect your bone density because it is going to affect your hormones. It's known to
Hmm.
also have cardiovascular implications, so it could negatively impact women's cardiovascular health long term. And I'm not even sure that all the mechanisms of why these things happen is really fully understood. But in my opinion, if there is an
Yeah.
alternative in this day and age, it should be looked upon as a last resort. And even the OB-GYN surgeons who perform these procedures, I think, are coming around to that fact because a lot of our referrals to evaluate patients for fibroid treatments are coming from a lot of our OB-GYN doctors in the area. So whereas we used to have, I think, OB-GYN surgeons initially might have thought of us as competition to them. We're offering non-surgical procedures. I think they're really coming around that it's just another tool in the arsenal for patients to choose from potentially, and that they can rely on us. And so I prefer to think of it as more of a collaborative relationship in this day and age, hopefully. And so we're always doing outreach with the OB-GYN surgeons and telling them about what we do. But just back to your point about hysterectomy, I absolutely agree. It should be kind of a last resort when there's just no other options left due to these long-term effects. And certainly somebody who's premenopausal, another thing to consider is that it
Wants to
actually,
have children. It-
well, yeah, obviously that's a non-starter, but it could even trigger early
and
onset
that's
menopause,
that's
right?
our audience here is
Yeah.
Sophia and I are so proud to be sponsored by TempDrop. TempDrop is a fertility sensor that you wear on your arm while you sleep, and it has a companion app on your smartphone that you can sync those temperatures with each day. That way, you can track your cycle and know your own body while you're tracking your fertility trying to conceive. This is an incredible tool. It's one of the first things I like to recommend to new clients. And if you're listening to this podcast and trying to conceive, consider yourself one and head over to tempdrop.com. One of the reasons why I love this brand and this company so much is how value driven they are. It was born out of a husband and wife trying to conceive and trying to figure out basal body temping and making it easier and in alignment with that value of making this information more accessible, they have just decided to lower their price. And in a landscape where everything is getting more expensive, I love that this company is making a bold move to make this product and this technology more accessible to women. So the new base price of this model is $189. This is incredible. You can even use our code FFF10 to get 10% off this new lower price. So head to our show notes or to tempdrop.com, grab yourself your fertility monitor, choose the size that you need, throw that code into the checkout area, and get tracking your basal body temperature today. We are taking a break from the episode, and I want to chat with you a little bit about Fertility Cloud. If you've been told you need help ovulating, or you have PCOS and you're trying to figure out your next fertility step, I want to tell you about Fertility Cloud. They make fertility care simple, transparent, and affordable, especially when it comes to ovulation stimulation and ovulation induction treatments. Instead of waiting for months to see a fertility specialist or getting hit with surprise bills, Fertility Cloud lists every price clearly right on their website. You'll see exactly what you're getting into and exactly what it costs. No hidden clinic fees, no surprise invoices later.
For my PCOS clients, this is huge. Their ovulation stimulation program can help jumpstart ovulation safely at home with physician guidance and medications delivered directly to you. You can do it all virtually, no driving to clinics or sitting in waiting rooms, and you can often even get appointments same day. If you're wondering, how do we do ultrasounds or what about lab draws? Don't worry, their concierge service helps determine where you can do that locally to you and coordinates with you on your behalf. It's just amazing. And here's the best part. If you're ready to take that next step, you can click the link in our show notes and get $50 off your first appointment. That means you get right in front of a fertility specialist for $115. That first visit gets you matched with a fertility doctor who actually understands your needs, and you'll walk away with a clear plan for your next cycle. So head to the link in our show notes, book your appointment, save $50 on your first Fertility Cloud visit, because fertility care should be transparent, affordable, and built for you.
Yeah. And so this is like kind of, no one in this audience is going to choose hysterectomy. Okay. But it's kind of like, that is often, too often, like, well, you have fibroids, so we can do a hysterectomy. If you want to do something about the fibroid, this is the thing we can do.
Right.
Or you can do nothing and we can try these other things. And these other things, unfortunately, can progress the disease state of fibroids. This is like all the hormones of IVF, like all the medicated cycles. And you would know this, Dr. Valenson, but like, we don't have hard and fast research that says straight up, if you do IVF, this is going to make your fibroids worse. Like, we don't have like a clear causal relationship between this. But anecdotally, I will say in my practice, I see it. I see this happening.
Right.
I see growth of the fibroids. If there are existing fibroids, they grow. If there were fibroids previously, we'll have recurrence, or we'll see new fibroids where there weren't any to start with. I'm not saying, I don't have like a, PubMed ID number to tell you about, like, go look at this data that says this. This is just Sophia's clinical experience. So take that with what you will. I'm not like telling you if you do IVF,
Sophia,
it's going to harm you, but
I think you make a very valid point in that in this field in particular, it's so difficult to perform these studies, right? Ideally, you want a randomized controlled trial where you are comparing treatments and control groups. It's so hard to do in practice. You just can't do it. And in your IVF world, where the percentage of patients who have symptomatic fibroids and are going through IVF, it's probably a relatively small number, but then you're not going to have a very good opportunity to do a controlled study where you randomize and put somebody in this group versus another. And so the point being, it's just so hard to come up with these preferred research studies that really prove things. So a lot of what we do with fibroids and in this world is based on very small studies with small amounts of data. And a lot of it is almost observational data, anecdotal data. And so if that's the only data we have, then we have to rely on it. So I think your perspective, even if it's anecdotal, it's still valid. And it hasn't been proven otherwise.
Thank you. Yes. I just don't want to present this as something that, we're looking at people's experiences that can be very skewed, because we're looking at experiences of people who have sought Sophia for help. So that's what subset of people is that, we're not like just going across broad populations and doing this. So, all right. Well, let's get into the options that you have. So nobody listening to this wants a hysterectomy. Nobody listening to this even wants a myomectomy, because I did, and I'll tell you right now, this was offered to me.
Okay.
And, the surgeon was like, yeah, I can cut this fibroid out. But so if you think about people that have like cesarean surgery, that we're talking about a clear, straight incision where we're not removing any tissue from the uterus. we are taking a baby out of the uterus, and then everything is sewed back up layer by layer. And
Hmm.
there isn't a chunk being taken out of your uterus. Now, depending on the location of the fibroid, the size,
Hmm.
there's lots of different things. We're cutting, like a football size cut out of your uterus and then sewing the muscle back together over this piece that was taken out. Because of that, the recovery is different. And
Hmm.
often women are told you need to wait at least a year before becoming pregnant because your risk of abruption, or which is
Sure.
basically like your uterus
Or
like
uterine rupture.
rupturing. Yeah,
Yeah.
yeah.
Right.
Your
Yeah.
of problems is higher.
Hmm.
And then we're not even going to attempt laboring. We're not going to put the uterus into that stress. We're just going to give you a C-section. And while C-sections can be life-saving for both mom and baby, they come
Hmm.
with a laundry list of risks that are not something that people want to do. And
Hmm.
you shouldn't
Right.
really be anyone's first choice, because we're talking about not just immediate risk to mom and baby, but we're talking about
Hmm.
lifelong eczema, life-threatening allergies, motor issues. Like, there's, of course, so many
Hmm.
babies are born via C-section and have beautiful lives, but the risk of complication in your life is more. And so you maybe don't want to go with this
Hmm.
myomectomy, which is like, the next step after, if hysterectomy is not on the table, we'll just remove the fibroid straight up. And I can see for some, I don't know, I'm
Hmm.
not the surgeon, but I imagine like a precondulated fibroid is kind of like zip. You move on, it's not like
Right.
deeply embedded in the uterine wall. But for some of
Sure.
these,
Sure.
it's a huge surgery. So,
Yeah. You bring up a couple of really good points. Okay. So, first off, you talked about just patient preference. And I think that's extremely valid because sometimes these situations are not so black and white. They're somewhat marginal. You could find yourself in a situation where it's not really clear whether a uterine fibroid embolization or a myomectomy is going to be very superior to the other treatment. But so in a situation like that, if a woman just has a strong preference, just like I do not want cutting on my body, I don't want to have surgery, I don't want this recovery, or I can't take off of work for that long, and simply just prefers a less invasive treatment like uterine fibroid embolization, even if the data may be slightly skewed in favor of the other modality, I think the patient preference is very important. So
yeah.
typically, when I'm seeing my patients, I really want to try to inform them of their options, not make the decision for them, and talk about the pros and cons. Because the truth is, all of these procedures have their role, and depending on the situation and the patient, may be more optimal for one patient versus another. And so I think it's would be very just kind of arrogant to just say that in certain treatment is going to be the best treatment for every patient in a situation.
Hmm.
Another point you
That's
brought up,
wonderful to hear, because I hear a
yeah,
lot of people really pushing for standardized care. And while that might sound nice, an
yeah.
individualized approach, in my opinion, is always superior.
No, no, it's paramount. I mean, you brought up, one of the most key points of fibroids that people forget about. It's like real estate, right? Just location, 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 right? Like it's,
Totally.
yeah, it's not just the size of the fibroid. Believe it or not, you can have a 10 centimeter fibroid that if it's pedunculated, like the ones you're referring to, right? If it's just sticking on the
Pedunculated. What was I saying?
pedunculated, that
Precundulated?
that's okay. I knew what
Oh,
you
I
meant. It's a
sound
big word.
stupid.
No, 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 it's a
No.
big word.
Okay,
I knew what you meant.
listeners.
I knew what you meant. But
Oh, please correct me
pedunculated.
when I do
Yeah,
that.
it
Oh,
just means
I
it's
could.
like it's on a stalk, right? And it's just on the
Yes.
outside of the uterus. And the abdominal cavity is pretty large and it might accommodate an 8 centimeter pedunculated fibroid and it might not interfere with the uterine cavity or having a
Yeah.
baby or anything of the sort. And maybe it's not a big deal. On the flip side, if this same size 8 centimeter fibroid is sitting inside the cavity, which I have seen with some of my
Hmm.
patients, well, now that makes pregnancy, a successful pregnancy, virtual impossibility because it's literally where's the baby going to be if you have a 8 or 10 centimeter fibroid sitting inside the cavity. So yeah, you brought up an excellent point. It's not just how big are the fibroids, how many are there, It's also where they're located. So there are going to be some situations where, even though I do what I do, I will recommend a myomectomy for certain patients. And if you want to get into a little bit of the details of when that might be the case, I think,
Yes, and I want to hear more about what you do. Like, what is
of
the option, and
course.
how does
Oh no, I
someone
can't.
know if
Yeah, I can't
they're
wait to
a
talk
candidate?
about what we do. Yeah, the first important thing is that you have to, obviously, we're just kind of talking here for entertainment and education, but consult with your physician. And if you feel like you haven't been presented with all the options, then maybe get a second or even a third opinion and know what these options are. But in my case, in our practice, we have to tailor every recommendation to the individual patient, which is going to be variable. Have they had their children yet? Or are they still looking to have children? How big are these fibroids? Where are they located? What are their thoughts about invasiveness, hormones, things of that nature? Um, but going back to the location of the fibroid for myomectomy, which is a point I was talking about earlier, there are going to be some situations where it's almost just like the perfect home run pitch, where it's just set up so well for myomectomy. And this will be typically fibroids that are actually fully inside the uterine cavity. So there's a classification system we don't have to get into, but typically fibroids type 0, 1, or 2, which are either in the cavity or at least partially in the cavity, and also not that large. And those are extremely amenable to what they call a hysteroscopic myomectomy. So that's a
So that's
device that
like
could actually,
it's inside the
yes,
what is the lumen of the uterus? What's that like
correct.
inner part
Yeah,
of
you
the
go through the cervix
uterus?
and into the actual endometrial canal, and you don't
Okay.
actually have to cut the patient open. And those can be evacuated sometimes quite easily, especially if they're not that large. So if they're maybe 5 centimeters or less in size and in that cavity, you can get them out basically virtually trauma free, minimal risk of bleeding, and that might be the best option for preserving fertility in that patient.
Mm.
But once those fibroids start to get much larger, there's increased risk of bleeding,
Mm.
increased risk of having to convert to a more
So what are
complicated
we
surgery. hmm
considering large or small in this situation? Like
Well, it
what
depends on
size
yeah, it
does it
depends on
need
the
to be?
location. It depends on the location, right?
Okay.
So if the fibroid is in the muscle layer or pedunculated, you could probably accommodate a much larger fibroid without it causing too much
Mine's not to
disruption.
brag, but mine's in the muscle
Yeah,
layer.
yeah.
Subserosal? Yeah.
And how big did you say it was?
It got to 11 at one point
Wow,
towards the
that's
end of my
impressive.
first pregnancy.
Yeah, I think by any standard, any location, that's a pretty good
But
size
it's only
fibroid.
3.5 right now.
Yeah, that's amazing.
It's like
Yeah.
it's like look at this little microphone here. It's like the little poof ball on this microphone.
Yeah, so it's interesting
It's
about
like
fibroids, right?
not so
So
big.
they have a life cycle of their own. And at any point in a woman's life, they can get bigger. And they can also sometimes, for reasons that are unclear, they could go into a red degeneration like you had happen and they could shrink. And sometimes postpartum, even having pregnancy for reasons we don't quite know, can trigger them to shrink as well. And then typically, once you hit menopause, they mostly, for the most part, all of them should start to shrink. But we didn't really talk what are fibroids to begin with. These are
Yes, that is. I really want people to understand that and the difference between a fibroid and a polyp,
okay,
because
sure.
that I think that gets
Yeah,
confused.
absolutely. Yeah. So fibroids are going to be the most common neoplasm in women in the uterus. So neoplasm, that means it is a benign tumor, but they're not malignant. They're not going to be life threatening, and they're just extremely common. They follow the life cycle of the reproductive hormones. So this is the reason why you don't typically ever see them in children. Typically, you have to have
Hmm.
puberty for them to start occurring. Although you were kind of in a rare box to be diagnosed with one at age 12 or in your adolescence.
Yeah,
That's extremely rare.
I was in like eighth
Yeah.
grade. I was really young.
Yeah,
So
that is incredibly rare. In fact, I still myself haven't really seen that myself. But so they tend to grow fairly slowly, and it's going to be variable as well. And at times, for reasons we don't know, they could speed up, slow down, and we could talk about things you can't control that might affect that. But for the most part, there have been studies that show that an average fibroid may grow 1 centimeter every 2 years. So do the math. If they don't form until you're maybe in your teenage years, every couple of years they grow. You might be in your 30s before you see symptoms, and that's what we typically see for
mm,
most women.
that's typically
Um,
what I see as well. And
yeah,
unfortunately, that's usually when people have already started trying to build their families and have quite a sense of urgency to build their families as well. Because it's
Yes,
like,
absolutely.
I mean, I'm 13 when I get this fibroid diagnosis. What do I care?
Hmm.
My uterus has a
Yeah.
problem. Well, I'm not using it for anything, so who cares? Like, that's how I felt. And I think of that like with the recovery from a myomectomy. If you're 22 or something, like, what? Oh, it's going to take a
Hmm.
year before you can get pregnant. Pfft, who cares? And I'm not, listen, maybe you're 22 and listening to this and you desperately want a baby and you have every right to grow your family at the time that works for you. And in fact, 22 is very biologically normal to have a child at. Maybe
Absolutely.
societally it seems a little young at this point, but biologically that is a great time to get pregnant. So please don't feel dismissed and feel like I'm another one of those people that goes, don't worry about it. You've got tons of time. Well, you do have time. You're not brushing up against menopause right now, but that doesn't mean that your uterine health means nothing. It doesn't mean that you don't deserve care or you shouldn't treat
Hmm.
problems and just wait it out until you are brushing up against menopause and then sound the alarm. That's silly. So if you know you have a
Hmm.
problem at 22, girl, address it. But
Yeah.
your timeline is different than the lady who's 38 and has already been trying for 3 years. And
Hmm.
now she's told we can give you a surgery with a 1 year recovery. That is a huge pill to try to choke down. And that's where something like what Dr. Valenson
Yeah.
could
Well,
potentially
one
have
year
an
at age
option.
35, yeah, is a big difference than 1 year at age 22, right? 1 year at 22
Mm-hmm.
feels like a drop in the bucket. At age 35, that feels like an eternity and could significantly alter your chances of a successful pregnancy. So there's no question about the timeline. But it is one reason why, as you said, when you have a problem, you may want to consider addressing it because time does tend to fly and it's easy to kind of forget about something, focus on school, career. And next thing you know, maybe you are a 34-year-old woman who wants to get pregnant, but now you have a 12 centimeter fibroid that's distorting your uterine cavity and actually may be affecting your chances of fertility or a successful pregnancy. And now, because you want to get pregnant, your treatment options are going to be more limited. So, one of the most important factors we consider in terms of treatment of fibroids is fertility, right? Has the
Mm-hmm.
woman had her babies or is she looking to get pregnant? And that's going to be a huge determining factor of what treatments you recommend for those situations.
So, what are the options that you have? We don't want to do a myomectomy because we don't want to recover for a year. We don't want a hysterectomy, dear God. So,
Mhm.
does what would you say you do here, Dr. Valenson? I'm just kidding. But
Yeah.
truly, like,
Well,
lay it on us.
yeah, no, I appreciate the setup, for the procedure that we perform. But, just going back to the whole myomectomy question, again, not all myomectomies are the same, right? So if it's a
Mm-hmm.
hysteroscopic myomectomy, I would wholeheartedly recommend that because it should not impact fertility. But then there's also if it's in the muscular layer or if it's pedunculated, right? Those are not going to be amenable to a hysteroscopic myomectomy. And now you're talking about a myomectomy where you are going to have to actually cut on the patient in some way or other and cut the uterus. And that could entail either a laparoscopic myomectomy or even open myomectomy. And depending on the size
Yes.
of these
Rough.
fibroids, yeah, it could hugely impact how big of an incision you make in the uterus, which can then have implications for later on OB complications, uterine
Mm-hmm.
rupture, things of that nature. So, um, assuming that most patients that we want to talk about here are looking to have pregnancy and want to have babies,
Yeah.
but now have
That's
fibroids that
why
they
they're
have to deal
listening.
with.
Nobody else
Of
cares.
course.
They're
Yeah,
it's the Food Freedom Fertility Podcast, Dr. Valenson. That's
absolutely.
why they're
Yeah.
coming to the show.
Of course, yeah. So, not all fibroids are created equal, right? And some of them cause primarily bleeding issues, and then some of them call what we call bulk symptoms. And bulk symptoms, like it sounds, are going to be related to just the bulkiness of these fibroids. So, when fibroids are large or in certain locations, they can disrupt the endometrial cavity where a baby would form. They can cause pain with intercourse, urinary bladder issues, constipation, a whole slew of issues that could definitely impact fertility. At that point, obviously,
Wait, and
uh,
you call it bulk because it's like you have this actual physical
yeah,
structure pushing on your
absolutely.
colon, on your bladder taking up an immense amount of space, making you have heartburn, feel
Yes.
full, making it difficult for you to run and play and live life. And you've got this big belly because you've got this
Absolutely.
big
Yeah.
fibroid. So that's what you mean by bulk symptoms, just for the
Bulk
listener.
symptoms. Yeah, exactly. Yeah. Some women describe that they can't fit in the same pants anymore, that they could actually see the fibroids, and they're very upset by just the look, the aesthetics of it. These fibroids really can affect your lifestyle. So a lot of people don't realize this, but chronic symptoms of fibroids has been shown in studies to be as disruptive as a lot of chronic diseases that are life-threatening, like diabetes, breast cancer even, which is kind of mind-blowing that it could affect you that severely,
Yeah.
cardiovascular disease.
Yeah, I
Uh,
mean,
re-
I'm impacted by it as well in pregnancy right now. Like
mhm.
every time I go see the midwife, she's like, "Oh, hello, baby." I'm like, "Not baby, that's the fibroid." It's like baby's foot or something, or knee is like pushing up out of the uterus. Nope, not
Yeah,
that's not who that is. There's just
your
like
other
this,
baby.
sort of doorknob poking out of the front of my uterus,
Yeah,
and it's a
absolutely.
fibroid. But thankfully, when I'm not pregnant, it's not like busting through my belly, and 3.5 centimeters is not enormous. But yeah, I experienced that too. And then the other side of it,
Mhm.
nutritionally speaking, dietitian here, is the bleeding that you talked about.
Yes. Yeah, absolutely. The bleeding can cause so many other symptoms when somebody's anemic or iron deficiency. It affects fatigue. A woman can feel tired all the time. It can affect brittle hair. Hair can fall out. Uh, People describe it impacting their relationships, their ability to
Mm-hmm.
perform their job, and just their overall life quality and happiness, and can require multiple rounds of transfusions and hospital visits. And when this is something that occurs frequently, it's, as you can imagine, it can really disrupt your life, and you're just not living your best life, your best version of yourself. So that's a whole other kind of symptom tree, is the bleeding versus the bulk. And
Mm-hmm.
then, of course, there's fertility issues as well, and the pain. So for that reason, whenever I counsel patients with this, I definitely want to have their OB doctors involved and talk about what all of their options are. So, as far as the procedure we perform that we're able to offer from an interventional radiology standpoint, that's an alternative to surgery and hysterectomy and myomectomy, this is a uterine artery embolization. So, when selecting the right patient for it, it's a great procedure. Has its pros and cons like everything else. And as regards to fertility, it's a very nuanced conversation we have to have with our patients. Historically, this procedure was not really recommended for people that wanted to have children or wanted to get pregnant, because when it was first invented, it was back in 1995, longer than I've been even went to med school. It was
Oh
thought that
my
it
gosh, I
might.
thought you were going to say longer than you've been alive. And I'm gonna be like,
Not
wow,
quite, not quite. No,
we
I
got
wish
a
I could make
Doogie
that statement.
Howser here. Or
Not at
maybe
all.
I'm
I
just
wish.
old. I'm not sure.
We're not. We don't have to go there. So I won't tell if you don't
I
tell.
don't, guy. If you're just listening, Dr. Valenson, he does have a fresh face. He's got a full head of hair that's all dark brown. I'm not seeing any significant signs of aging here on him. So if he told me he was born in '95, I might have believed him.
Oh
But
wow, you flatter me there, but I'm not going to get too close to the camera here and show all my blemishes. Yeah, but anyhow, when the procedure was first kind of invented, people had to theorize what would this cause, kind of effects what are going to
totally,
happen to the uterus, and there were some concerns that hypoperfusion, right, to some extent, you are kind of going to decrease blood flow to the uterus.
yeah.
Can that have long-lasting impacts? And for the most part, we don't really think that that's a real thing, but the data is so limited, like we talked about before.
Mm.
Um, there are really, I don't know if there's any randomized control trials that exist. And I'll give you an example. What's considered one of the better studies that I've encountered. They followed 8 women who had a uterine artery embolization,
Oh my
who
God,
got
that's
pregnant
such a
shortly
small
afterward.
sample
It's
size.
such a laughably small number, right? It's
Yeah.
just actually, it's almost pathetic that we even have to quote a paper of that size, but that's what it is. And out of these 8 women, 5 of them went on to have a live, healthy baby.
Mm-hmm.
2 of them, pregnancy did not succeed for what
Mm.
reasons, I'm not sure. And then one of them chose to terminate the pregnancy. So depending on how you look at it, marginally successful, right? 5 out of 8 is not horrible, and then one chose to end it. So there definitely are some effects, but there is a misconception of how uterine artery embolization affects fertility. People think the concern is that it will lower your fertility when that's not really the main concern. Um, Amongst the limited data that we have available, it's not really indicative that it actually does affect your fertility at all. If there's any effect on fertility, it's probably minimal, if at all, meaning that a woman can and should be able to get pregnant after uterine artery embolization. The issue becomes more in just OB complications, right? What happens later during the pregnancy? And there is some data that indicates that it could affect certain things like there's been some trend towards premature, not greatly premature, but maybe 35 weeks or something of that nature, restricted fetal growth size, some placental complications. And that's where it gets really murky, because having large fibroids would also lead to a lot of those similar kind of complications.
Right. I'm glad you said that, because we're not talking about a woman with 0 uterine abnormalities and then versus a woman who had an embolization for fun. Like, we're talking about outcome of a fibroid pregnancy, or I wish, for so many of these women, I wish you would have a fibroid pregnancy, please. That would be delightful.
Yeah, exactly.
No pregnancy, or a pregnancy that never makes it past a couple weeks, unfortunately, is who I am working with most commonly.
Right.
And we don't really know why these fibroids are happening. And so, is the reason why you're having fibroids the reason why you're struggling to get pregnant? Is there some sort of hormonal signaling that's not happening? Are you, we're seeing more like progesterone resistance, as that's like something that can be happening. Maybe your uterus is just not responding to progesterone. Is it that there's some level of inflammation that's happening, and so that's preventing you from getting pregnant?
We're going to take a break from this episode to hear about one of our sponsors. You've probably heard me say this before, but preparing your body for pregnancy is not just about you. It's about both of you. Fertility is truly a team effort, and that's why I love the Fullwell Fertility Trio for Two. Fullwell was founded by a fellow registered dietitian and fertility expert, Ayla Barmer, and this bundle was designed to support both partners in the months leading up to conception. It combines their top-rated prenatal vitamin, omega-3 fish oil, and a fertility booster supplement that covers things like CoQ10, N-acetylcysteine, alpha-lipoic acid, and organic ashwagandha root extract. The nutrients here support overall egg quality, sperm health, fertility, and even your stress resilience. If your partner's semen analysis looks normal, or if it's suboptimal and we need to improve things, nutrition plays a key role for things like sperm motility, count, and DNA quality. For women, these same nutrients help with ovulation, egg development, and healthy hormone balance, not to mention mitochondrial support, which is a huge piece of how your gametes mature and get ready to be that queen egg or that king sperm that make it to combining to form an embryo. These things are foundational for a strong, healthy pregnancy. I personally love that Fullwell's formulas are third-party tested, they're evidence-based, and made with doses that actually match what the research shows we need. No fluff, no underdosing. So if you're planning to start trying this winter or sometime in 2026, or you've been trying to conceive for a while, it's time to think about starting to nourish your bodies for what's ahead, or take a step up from your current protocol to one that is high quality. Head to fullwellfertility.com and use the code FFF20 for 20% off your order. That's FFF20 at checkout. I'll drop the link in the show notes for this specific fertility trio bundle and for Fullwell, along with this code FFF20. Give yourself and your future family the best foundation with Fullwell's Fertility Trio for Two.
We don't really know. And so here we are. We see this fibroid. We know clearly that women with either large fibroids, numerous fibroids, fibroids within the endometrium, are having harder times getting pregnant, worse pregnancy outcomes. So let's blame the fibroid and let's maybe get it out of there, treat it, shrink
Okay.
it, let's
Sure,
see how
sure.
that goes.
Yeah. Yeah. So yeah, let's get into how we would treat it with our procedure. But yeah, just to reiterate the point, right? With these studies, they're confounded by the fact that in addition to, like, let's say you didn't have your fibroid treated, what kind of complications may happen as a result of the fibroids, which is exactly what you're talking about. And it's probably going to lead to more issues if you have a massive fibroid in your uterus and trying to have a healthy pregnancy. And then the other confounding factor is that fibroids tend to grow and increase with age and with time. And so with these studies, it's very hard to distinguish, is it the fibroid? Was it the procedure they had? Or is it just simply the fact that the woman is also of increased age where they're just going to be more likely to have these kind of complications? But let's assume now that I have a patient in my office that I think is actually a uterine artery embolization is going to be their best bet. And it can be for a variety of reasons, scenarios. And that's why I think it's always important to consult with your doctor, consult with your OB. And if you are considering the kind of procedure that I do, consult with your interventional radiologist as well, just your friendly neighbor interventional radiologist.
We all have one.
But, yeah, right. Right on every corner, right? Hey, we're increasing in popularity. More people are going into the field, so we're kind of excited about that. We do think it's definitely got a good outlook. But let's say I have a patient who wants to have pregnancies, but myomectomy is not looking like a good option at this point. Maybe the fibroid is just absolutely too massive, and they're going to be trying to do a myomectomy. They're going to potentially bleed so much, they're going to have to convert to an open hysterectomy, disaster, that kind of thing. So it's just really not safe. Or there's many women that have 20 fibroids, even more. And so what are they going to do? They're going to go in there and surgically remove 20 different fibroids? It's just not going to happen, right?
But that's...
Well, I mean, at that point, you just remove the entire uterus, or they have to do what they call staged procedures, where maybe they get a few of them, come back, and by the time they do multiple of these surgeries, the long-term health of the uterus is severely compromised as opposed to the procedure that we offer. So it's definitely an option for many women. And so what uterine artery embolization is, the procedure that we do, is you basically block the arteries that are supplying these fibroids. And fibroids are essentially tumors. Yes, they're benign tumors, but you can think of them as a tumor, and they need blood. And they like to hijack the normal vessels, grow them to supply themselves more blood and increase growing in size over time. And so if you cut off the blood flow to these fibroids, they will shrink and they will eventually degenerate and die. And the shrinkage and stopping the growth is what leads to the symptomatic improvement. So this procedure that was invented way back in 1995, and it's done quite differently now, but the concept is still basically the same, is you get a tiny device, what we call a catheter. It's a long plastic tube that's about the thickness of a spaghetti, essentially, which is kind of amazing, but we're working with really tiny devices. And in our practice, we like to go through the radial artery. So in your wrist. So this artery right here. Yep. Everybody's got two of those. So this is a 2 millimeter size vessel, very small. And so the fact that we can do it through this tiny artery is really kind of amazing. It leads to a lot decrease of risk factors, bleeding, post-procedure pain. And most of our patients go home about an hour or so after the procedure. And the whole procedure can be done in typically less than an hour, start to finish. So once you puncture that artery, you go up the arm and down the aorta, which is the largest artery that comes out of the heart. And it's going to split off into your iliac arteries, left and right side, where your uterine arteries come from. You maneuver this device using an X-ray and steer your way into these uterine arteries that are supplying these fibroids. And then you inject these little particles, or beads as we call them. These are made out of a variety of substances, but for the most part, some combination of gelatin and PVA, or essentially plastic. They're tiny. They block up these vessels, and then that's going to lead to the fibroids being deprived of the blood that they need to survive. And typically over the next few days, it will start to shrink, degenerate, and that will lead to the symptomatic improvement. In our practice, we're able to do these procedures typically in under an hour for the most part, and send our patients home about an hour and a half later. And the full recovery takes about a week before we tell them you can pretty much go back to doing most normal activities for most patients. So compared to surgery, the recoveries of surgery, having to deal with things like adhesions and scar tissues and placental or uterine complications down the road, it's really kind of a game changer of a procedure that I feel very privileged to be able to offer to people.
Wow. Okay. So a million questions here. And this is so all right. I want to just talk to you sort of anecdotally now, Dr. Valenson, like not
Okay.
what does the data say and what does your training say and everything like that. What kind of follow-up do you have with these patients? And like how often are you seeing healthy pregnancies result after somebody has had this?
Yeah, so that's going to be pretty anecdotal evidence. So,
I mean,
we,
I got you sitting in front of me. I just want to know what
of
you're
course,
experiencing, your clinical
yeah, absolutely.
experience.
Yeah, about 2 years ago, we had a patient, for example, was not even trying to get pregnant, didn't want to get pregnant, got pregnant about a month after one of these procedures, a uterine articulation, and went on to have a healthy pregnancy. This kind of thing happens all the time. It's frequent, but it is anecdotal, right? And we don't really have any large studies of this. So, but like we talked about before, the uterine artery embolization should not really affect fertility to the best of our knowledge. But we're also thinking about the entire pregnancy, the health of the pregnancy, and complications. So that's where the data is less clear. But like in that one small study we talked about, the majority of patients did have healthy live pregnancies, and so it's certainly something that does commonly happen, especially on an anecdotal note. Most of our patients, when we do the procedures, 90% of them are going to get that clinical improvement. It's not perfect, but in our world, that's actually pretty good. 90% success rate is pretty good. Typically, within 1 to 3 months, they're going to be considered fully recovered. And, I would not have any restrictions in terms of trying to get pregnant at that point. Just want to have close follow-up monitoring just to ensure a healthy pregnancy throughout. There are some situations I've encountered where it seemed like the procedure that we offer was really going to be the only pathway for that patient. As an example, I did have one patient who had about a 10 or 11 centimeter fibroid, but it was sitting right inside the cavity. She could not get pregnant.
Okay.
She had gone to a fertility specialist. And unfortunately, it just was never going to happen with that fibroid sitting there. It's just not possible. And you're not going to be able to do a myomectomy on that fibroid, or at least I even tried to talk to several OB surgeons about it, but the concern for bleeding was just too great. And if you're in there trying to remove a fibroid and you run into some bleeding issues, again, you may end up with an emergency hysterectomy, which nobody wants. So that was a
Yeah, for
situation
real.
where, we could offer her the procedure with, good faith and optimism and see what happens. And then once that fibroid shrinks down later, we can work in conjunction with an OB doctor who then can come in hysteroscopically and kind of evacuate what's left of that fibroid, and it's not going to bleed and it's going to be safe. So like I was saying before, I prefer to think of the OB-GYNs as, just a collaborative approach in certain cases
Mm-hmm.
to just give women all of their options.
So what it sounds like you're saying in that situation is
Mm-hmm.
the procedure that you did was sort of like a
Mm-hmm.
stepping stone to be able to have it removed down the line because it had shrank and it wasn't as vascular and it wasn't as much of a risk.
Exactly. Yeah. We were trying to
Okay.
devascularize and shrink that fibroid because every OB I talked to about it, they seemed just terrified that if they touched it the way it was, it's almost like they just thought it was going to like explode
Yeah,
and
like a
just
bomb.
bleed everywhere.
Yeah.
Yeah. And that would be a terrifying scenario.
Hurt
And then they
locker.
might, yeah. And then at that point, you're stuck doing a hysterectomy and you're going to be calling
I
your
cannot
lawyer. And
imagine.
it's a bad
That
day for
is
everybody.
so terrifying.
Yeah.
Listeners, you might know this if you've listened to Dr. Valenson. You don't know this, but about, I don't know, 14 months ago, or not even 13 months ago, maybe, I had an ectopic pregnancy that ruptured and had to go into
Oh, wow.
emergency surgery. And by truly the Lord's hand on my life, it was the same surgeon that had done my embolization of my fibroid and had done my endometriosis excision. I actually, when I
Okay.
tried so many things to try to not have to go, you would like laugh at this. My neighbor is a radiologist. And so
Mm-hmm.
I was like, when I found out that this was ectopic, I was like, oh no. And so like go to the ER, get the methotrexate. And they were like, look, we could operate on you right now if you want, but we're going to take a tube and maybe more. But it
Mm-hmm.
doesn't look like it's ruptured, so we can give you this drug and you can at least try that. But you are not to just go home and think all is well. You must follow up in 48 hours or however long and make sure that this is working. Well, they didn't ever communicate that to anyone. So I didn't want to
Oh,
just go
no.
back to the ER and go through triage and all this crap. And so I tried to kind of like call my doctor who had done my fibroid thing and been like, hey, can I just come in there and you can like look at this and see if it's smaller or bigger than it was 2 days ago? Well, she was in surgery all that day. And so there was no one to look at it. So I call up my radiology neighbor. I was like, okay, Bryson, like, can I just like FaceTime you with this sonographer and like, I'll send you like the last scan that I had and just tell me if it's bigger or smaller. Like, is this gestational sac shrinking? And he was like,
I'm sure they love that,
no.
right? Just put them right on the hook.
No, Sophia, what? He's like,
Uh-huh.
first of all, I work in cardiology, so what the hell do
Yeah.
I know about this?
Mhm.
Secondly, this is insane. Like, go to the hospital, you quack. But I was like, I don't want to do that.
No,
And
they
so
don't want that liability.
I actually hunted down where the surgeon was that day. Like, what OR is she in? And
Uh-huh.
I'm going to go there and
Oh,
have her do this. So, cause she knows what's up. Right. And so I go in there, and by the time I'd gotten in there, it was so wild. Like, I laugh about it now, but like extremely traumatic. I had a rupture. I was hemorrhaging internally. And
Oh, my
so
goodness.
it was really rough. Right. It was a bad day.
I mean,
So when
but
the
thank
surgeon
God you were so persistent, right? And just followed up on it to where
yes,
you would
it
corner
didn't
the
get to the
surgeon,
point where I
basically.
was like,
Yeah.
by the time, I will tell you this, like, I didn't feel that bad. Like, I
Mhm.
felt worse at times in my life. Absolutely. I didn't feel that bad. But I will say, by the time I was walking into that OR, like when I like stood up to get onto the table, I was like, oh, whoa, like
Mhm.
starting to
Yeah.
not feel good, really not feel good.
Yeah.
So it was approaching a point where I would have sought more care, but thankfully they got me. I had only lost about 1 liter of blood by that point, which is actually quite a bit of blood,
Wow.
but like,
That's quite a bit. Yeah.
it's quite a bit, but not like, not like
Yeah.
death. I didn't need a
Not going to take you
transfusion,
out
like
immediately.
not
Yeah,
going to take you out, but you'll feel it. You won't feel good. So, anyway, when she was like getting ready to put me under, she was so casual and was like, this is going to be fine. Yes, you're hemorrhaging, but think drinking fountain, not fire hose. And I was like, okay. And so then I was like, okay, don't sterilize me. She was like, I won't. What? You know, like don't give me a
definitely not the goal.
hysterectomy. And she was
Yeah.
like, I won't. It looked like sort of a look on her face, like, what are you talking about? And I was like, I have seen this happen. I have had patients where they wake up in full menopause, no tubes, no ovaries, no uterus.
Yeah.
It's all gone. And she gave me a
typically
little
something
wink and
might
was
have
like,
gone wrong in that situation, right?
I'm sure.
Yeah,
And
unplanned.
but she gave me a little wink. She's like, well, they didn't have me for their surgeon. And I was like, okay.
See, but when it comes to your surgeon, I think you want that a little bit, right? You want that
Yes.
swag,
Confidence.
that confidence, right? To an
You
extent,
do.
you don't want them to be arrogant or have too much hubris
No,
about it,
and she's
but
not.
it's-
Or I guess
Yeah.
it depends on the surgeon. For gynecological surgery, I want that kind of attitude. I think for
Yes,
like
at
neuro,
least a little
I
bit.
want somebody that can barely hold a conversation with me. That is
You want the nerd.
so
You want the nerd. Yeah.
the nerd, the person
Yeah,
that
big time.
loves surgery so much. We're
Yes.
talking about like a young Sheldon type. That's what I'm looking for here. Somebody that's
Yeah.
like definitely on the spectrum and their special interest is brains. That's
100%,
who I'm looking for. I don't need somebody that's going to like tell me a joke. I need somebody that's going to get it done. But that was a very real scare going into this, was like, please don't take my uterus.
Yes,
And
absolutely.
so here we are, the other side of this long ass story I just told. Dr. Valenson providing a procedure where that's really not even on the table. That's not even like a risk of this. Like, that's not even like a conversation you would have in going into this, is like, well, maybe this could result in hysterectomy. Like, I would think like about 1,400 things would have to go like extremely horrifically wrong in order for that to even be a potential for the kind of procedure you're doing?
Yeah, the only time that's really in the equation is when the patient's fibroids are so bad that they're basically looking at a hysterectomy or else they have no other options. That's the only time when you might
And they're sort
possibly
of
do the
throwing a Hail
procedure.
Mary to you. Okay.
Yeah, and then
Yeah.
you're going to try to avoid it, but then it might still lead to that. But yeah, just to lead to it when it wasn't on the table to begin with, that would be, exceedingly rare. The procedure, fortunately, it's quite safe, and the kind of complications
Have you ever
we
had to
see.
have that happen?
Not with one of my own patients, but we have a very large practice and just a lot of doctors performing hundreds of these a year. That has happened, but it has typically been in uteruses and fibroids that were just so massive that it was the only alternative to try to prevent them from getting hysterectomy. And in some situations, with a successful procedure, as the fibroids start to kind of necrose and die, when they're really, really large, it can sometimes trigger a massive inflammatory effect or even like an infection or something where that might be necessary. So, that's why I always want to
But
temper
you've
these
never had it happen
procedures.
with one of your actual patients.
I've not had it
Just
happen to
it's
one of my
happened in
patients.
your practice, other people.
Yeah, it has happened. And, it's the kind of thing that it's going, you do enough of these kind of procedures, there's going to be something like that can happen. But again, in those situations, I think that woman was headed towards that. If not to try this procedure, that was they were going to get the hysterectomy anyway. So, we don't want to have that happen, but you might argue that we just try to avert that, and we're not able to do so in that particular situation. Oh, no, I was going to say that the procedure is, extremely safe, and serious complications, fortunately, are rare. And when there's a handful we have to talk about that are realistic and, fortunately can be dealt with antibiotics, anti-inflammatory medication, things of that nature for the most part.
So, okay, I love what I heard you say just now, that these doctors are doing hundreds of these per year. That is, listener, that is the kind of talk you want to hear from someone that's going to do a procedure of any kind on you, whether they are lasering off a mole or whether they are opening your skull. You want to hear that this is what this guy or girl does all day, every day. They're great at it. They're extremely practiced, and they've, hundreds and hundreds of these cases. You don't want to be their 50th time. You want to be their 950th time. You want to be the person who you want to go to the guy that does this all day. That's a really comforting thing to hear, is that hundreds per year. Love it. I saw something some point. I don't know. I think it was. So I have a friend in medical device sales. And so I was like, okay, tell me for real, at what point does a surgeon become good with this robot or whatever the hell it is, you're using? And she was like, honestly, from a sales perspective, we're supposed to say, it's so easy, it's so fast, it's whatever. You don't need a bunch of training on this. But she's like, in reality, if I was going to go have a doctor operate on me with this, she had a robot that was her thing. She was like 500, 300 is where I would consider it. 500 is where I would feel confident. If this guy had done this thing 500 times, I would be like, all right, cool.
Yeah. You have to stay humble. The human body is an amazing miracle, but there's just so much variety. So the more you do, the more you see. And, every now and then you're going to see something you haven't quite seen before, but the more of these you do, then the more experience you have with maneuvering those. And that applies to anything, right? Like they say, 10,000 hours to become an expert at pretty much anything.
I'm an expert on worrying and staring at blank pregnancy tests. And that.
I mean, I think we're all experts at worrying. I can't comment on the pregnancy test thing,
I'm
but
an
yeah,
expert
worrying
at looking
for sure.
at negative tests and hoping it is positive. If 10,000 hours is the marker, I've arrived.
Trying to will it into existence, just kind of squint, see if you can imagine that line there.
How sad is that? Oh, that's sort of a joke, but it's also sort of not a joke.
Yeah, no, that's human nature, But going back to these, procedures in general, right? So I always tell patients that in some situations, their input is paramount to making the decision because all of these procedures are there for a reason, and some of them have their niche, their role, their place. And we say in surgery that when you're a hammer, you walk around and everything looks like a nail. And the hard part
Yeah.
sometimes is remembering that you don't have to whack everything that you see. And I think the hysterectomy thing kind of has that reputation a bit.
Yeah.
But even with what I do, I try to also keep that in mind. And just, whenever I can honestly say to a patient that, hey, there's an alternative procedure that I think might be better for your situation, my job is to inform them of that and let them know. But, just really educate the patient, let them know what all of their options are, and then help them make the best decision. Fortunately, I think what I do is very cool, very cutting edge. We're doing more and more of these procedures. We're able to really target the tiniest vessels and get so specific. So even what we do, the UFE procedure itself, is constantly evolving. The devices are getting more intricate, more targeted. And it's really, really exciting. So I feel really fortunate to have kind of stumbled my way into this women's health world that I never quite expected. It is a subset of other types of procedures. For example, on men, we treat the prostates, which is kind of like the male uterus. And they have a lot of kind of similar challenges in a sense. And I think that it's only going to continue getting better and better. But women have to really educate themselves, talk to different specialists, do their research, and also keep in mind their own personal beliefs and desires, whether that might be going less invasive or improving their chance of fertility. And I think for that reason, I never want to make a generalized recommendation. I want to take it on a case-by-case basis with each individual patient. Where are they in their journey? Where are they with their fertility goals? I'm a big fan of imaging. That's why radiologist is in the title. We just like looking at pictures and kind of figuring things out and discussing it with the patient. And I think that's really important. It's just my best advice to a patient would be to find a provider that you can have these kind of conversations with and is kind of willing to listen and factor in what the patient wants as well.
Okay. So final question before we button up this episode.
Sure.
How does someone begin to think they might be a candidate for what you're doing? How would they find somebody like you? Is this only in Houston? Like, talk to the gal who's listening, who's like, oh my gosh, okay, an option for my fibroids. What do you have to say to her?
Yeah, no, I think interventional radiologists, like we talked about, we're like your friendly neighborhood Spider-Man. We have spread all across the country now. We're not that rare anymore. And I think, Houston's the fourth largest city in the country, but we have a role pretty much everywhere, even in more rural areas. So interventional radiology is definitely out there. I think anybody that has fibroids, I strongly encourage you to start with your OB doctor, of course, and get evaluated and listen to what their options are. But if you're at a point where what they're recommending to you is some kind of a surgical treatment, and that would mean that other modalities have not worked for you, like say hormonal therapy or NSAIDs or tranexamic acid, a bunch of things that we didn't really have time to get into.
We've talked about TXA a bunch on here because I've used that quite a bit.
Okay, there you go. But if you're at the point where now it's like, the fibroids really are not responding to anything, and you're going to have to be dealt with directly in some way or another, whether that be a myomectomy of some sort or a hysterectomy, at that point, a uterine fibroid embolization is likely going to be a potential option for most patients. And so that's when I think you can definitely look at that, especially if you desire a non-surgical route. I would hope that most of your patients are really not looking to get a hysterectomy for the reasons we talked about. But even a myomectomy, like we talked about, it is a surgery and sometimes can be quite a big surgery. If you're at that point, then I think it's reasonable to consult an interventional radiologist or even ask your OB doctor about it. Many of our biggest referring providers now are actually OB doctors, as they have accepted the procedure as a viable alternative, and especially the ones that really just want to also offer their patients all of their options. They actually might know of a good one that they can refer you to, like we have here in Houston, where a lot of our referrals come from the OB doctors. But anybody is able to do their own research. And if you're at that point where that's what you're looking at, either myomectomy or hysterectomy, then uterine fibroid embolization should certainly be an option for you as well, a non-surgical management. And yeah, interventional radiologists are the ones who perform these procedures exclusively. And in our, we are vascular interventional radiologists. So we pretty much stick to the vascular system in general. And we consider this a vascular procedure.
Definitely.
So,
Yeah. Your
mhm,
uterus is extremely vascular and very
absolutely.
uniquely vascular at that,
Yes. Yeah.
because it is the way that the blood volume can change, and the
Hmm.
way that these blood vessels stretch and move is unlike any other organ in the body.
Yeah.
And then how quickly they can change too, like the way your blood will perfuse after you've just birthed your baby and the placenta detaches. Very, very fascinating. Your
Yeah.
uterus is such a dynamic organ. Very, very cool. I can see why you ended up there, like why, of all the body parts to work on, why this one became your special one, because very, very interesting things going on there that are just not happening anywhere else in the body.
100%. In fact, the procedure wouldn't work if it wasn't so vascularized and if it didn't have multiple ways of getting blood to that uterus. You wouldn't just be able to just go in there and just cut off the uterine artery because the entire uterus would just not survive. So, to your
Yeah.
point, yeah, it's that amazing multiple backup collateral system of blood flow that allows you to even do the procedure and make it successful and target that fibroid while keeping that uterus alive and viable and healthy. So, yeah, I agree with you 100%. And that's part of why we're so passionate about this field.
Well, another way to further uterine health. So thank you for sharing your expertise with us today. Thank you for giving us your time. Of course, I know it is people like you, they want you in the treatment room and not doing a bunch of other things. But so we're really happy to have you on here. And listener, I hope this gave you a lot of hope that there are options beyond myomectomy at times, and certainly options beyond hysterectomy. How terrifying that must be to hear that that's the treatment recommendation for someone who wants to have children. So, yeah, and as a fellow fibroid haver, I don't even want to say sufferer. I'm trying to make friends with my fibroid, Dr. Valenson. I'm
Well,
34 weeks pregnant right now, so it's like this
yeah,
baby's coming and I'm going to have to work alongside this fibroid. We're going to have
but
to
it
work
sounds like
together to
it
get this
sounds like your
baby out.
fibroid is cooperating with you and has shrunk significantly, right? Kind
So
of,
far so good this
right?
pregnancy, and so and it has caused zero pain. I am thankful, beyond thankful, that this fibroid has
Hmm.
not hurt for a single moment. I have had no degeneration, really not anything like my last couple pregnancies.
Hmm.
So I'm very, very thankful for that. And but we've got one big thing to do. And since this is in the muscle tissue, and the
Hmm.
muscle is about to have its time to shine when it comes time to push this baby out, me and this fibroid are going to have to work together. So, yeah, I'm trying to have sort of a positive attitude towards her and not be so mad at her, because, and honestly, I think she's a communicator telling me
Hmm.
things that my body needs. And so in a way, maybe part of me was like, after having that uh, radio frequency embolization, which maybe we could have talked about how that's different, but
Hmm.
after having that and then having it be deemed a failure because it didn't get any
Hmm.
smaller, in fact, got a little bit bigger after that, and then having the ectopic, and then because of that, like the timeline to having another baby was pushed so far back, I was like, damn, I could have had a myomectomy. Could have just
Possibly.
cut this
Yeah.
bitch on out.
Oh,
Give her the
hindsight's
old
always
heave
2020.
ho.
Yeah.
I know, but
Well,
then at the same time, here I am getting ready to have my third and final home birth. So I don't
yeah.
know how wise that would have been if I would have had the fibroid completely removed.
You never know. And it looks like you're kind of in the home stretch of a marathon. And so far, so good. And the human body, the uterus, amazingly resilient. And in the grand scheme of things, for it to be located in the muscle 3 centimeters, I think there's a very good chance you're going to be
Right
totally
in the
fine.
front. Yeah, that was what was
Yeah.
also so awesome when we had our first. I went and got a really early scan with this pregnancy as an ectopic pregnancy survivor. I was like, are you in my uterus? Like, where are you? What are you
Yeah.
doing?
Sure.
And so as soon as my HCG levels reached where there would definitively be something to see, I was like, okay, let's go get the scan and like see where this pregnancy has landed. And my fibroid is right on the front of my uterus, like just a little below my belly button.
Okay. Yeah. Leading
And
the
the
charge.
baby is right at the top of the uterus, like a disco ball up there. That's where, I mean, now the baby is everywhere in the uterus, but like
Right. Right.
when it first began, it was like a little chandelier. And
Uh-huh.
so it was like, oh, baby, you are so smart. Good job not putting your placenta on this damn fibroid. I'm so glad you are
Incredible.
nowhere near
Incredible.
this thing and you
Yeah.
just
It,
ran
it, it
far
sounds
away.
like it sounds like that fibroid's cooperating and all is well. So I wish you the best of luck. And
Oh, Lord, I'll
how,
take it.
yeah.
Not
Well,
looking
thank
forward
you
to
so
this
much,
one.
Sophia. It's been a real privilege to be on the show. There's a lot
Yeah,
of
we're
amazing
so happy
content
to have you
here.
here.
Hey, friends, we're taking a break from our episode to talk about one of our sponsors. And this sponsor is the PCOS app. Did you know that I made an app all about PCOS? Well, I did, and you can find so many resources in it. We have slowly moved all the resources from my PCOS Hormone Academy course over into the PCOS app, and that talks about all things PCOS topically. Like if you have acne, you can go look at the skin and acne modules and see what does Western medicine offer? Why does this impact PCOS? What can we do about it? What are natural remedies? What are nutritional remedies? We talk about hair loss and hirsutism all through that lens where we go through what is it? Why is it impacted by PCOS? Or why do we need to pay more attention to this particular thing? And what can we do about it? And we provide a vast resource to help you both advocate for yourself at the doctor's office and treat yourself at home naturally. Now, the exciting thing that I want to share with you is starting in January 2025, we're starting to migrate all of the content that I have published so far on fertility into this app. I used to sell a course for $700 all about how to get pregnant with PCOS, and that is all getting moved into the app between January and March. So you can take the course as if you enrolled in the whole thing for $10 per month. So head to your app store, whether you're on a Google Android device or an Apple device. If you type in PCOS app, you just look for that really pretty lavender flower, you'll find it. Download it and join us because you're going to get weekly recipes and all the fertility focused PCOS content that you need. It will start being uploaded under the Academy tab. So stay tuned for that. And let's get back to our episode.
Hey, it's me again, Sophia Pavia, registered dietitian nutritionist specializing in women's health, fertility, and optimal progesterone production. And I'm interrupting an episode of my own podcast to tell you about my online course called Ovulation Unlocked. So if you've been listening to our podcast episodes, you've probably heard a lot of things about basal body temperature, cervical mucus, cervical position, and tracking your fertility. Well, I have designed a 90-minute self-paced online course, which I titled Ovulation Unlocked, that puts all of that together and teaches you how to be the expert on your own fertility from home. This course is designed to put you in the driver's seat of your own fertility, not only so you can know what's going on with your body on any given day, but so that if you need medical help, you can show up to the appointment informed and ready to communicate. Too frequently, us women show up to our doctor's appointments and just say something like, I want to have a baby. And the doctor looks at you and says, good for you. Stop using birth control, start taking a prenatal, come back in a year if you're not pregnant. And that's all we get. However, Ovulation Unlocked puts you in the driver's seat, puts you in control of your fertility to where if you need help, you can show up to that appointment informed and ready to communicate your needs. So if you want to become the expert on your own body and your own fertility, head on over to my Instagram bio and tap the Ovulation Unlocked link today.
So
So we always end each episode with something that we call the yeah girl, but for you're not a girl. So we say
okay.
my man if it's a dude on the show. So basically what we do, because we do cover, I mean, this episode was largely very positive and informative, but sometimes we're having people on, talking about loss and trauma and all the things that can come along with pregnancy and fertility. So we like to end on a positive note where we do the yeah girl, which is where we talk about anything in your life that you are pumped about right now. This can be anything from a huge professional certification or something like that, that was years in the making, or something as small as I found a burrito that's very flavorful without being too spicy or something like
Yeah.
that. So,
Okay.
I'll go first so you can catch the
Sure.
vibe, and then we would love
Gotcha.
to hear something from you. Okay. I was in
Sure.
Houston 3 weeks
What?
ago. I went out
Okay,
there.
yeah.
Yeah. I was just there. My husband and I went out for a fundraiser event. He's a bit of a war hero. And so he got invited to this fundraiser where basically, you know, rich people pay to sit next to war heroes. So we got like a 3-night stay in at this fancy hotel, the Post Oak.
Oh,
And,
I know it. It's one of the nicest
you
in
know
town.
the Post Oak. It
Of
was
course.
fancy.
Yeah.
And
Yes.
we went and had truly the best Japanese meal we've ever had at Kata Robata in Houston. I don't know if you have been there, but
I
it
live
was
2 miles from it, and I've been there
Oh,
many
you-
times.
so
Yeah.
you know. Okay.
Of course, I know Kata. Yes.
We had a great meal. It was so delicious. We got there Wagyu beef skewers. We got all different fish dishes. And the dude sitting next to us was like, this is the best restaurant in Houston. Like this, you're going to love this place so much. And so he treated us to a mango shave ice at the end of our
Wow.
meal. And it
Very
was
Houston.
so
Yeah.
good. So we had a great Houston experience. And so that's my
Love
yeah
it.
girl.
Love it.
It was
We're
a really
very
fun
proud
meal.
of our food here in Houston. We have an incredible food scene, and it's very debatable what's the best sushi in town, but Kata is always going to be up for discussion. Depending
Yeah,
on
it
if
was.
you like if you like foie gras and wagyu on your sushi, which why not? Then
It was
it's definitely in the
wild.
conversation.
Yes.
Yeah.
Yes. And like even
Yeah.
some what did we get? Like some papaya salad or something that we were like, it just didn't sound like much. But the guy sitting next to us was like, you got to try the papaya salad. And so I was like, all right, well, whatever, we'll get
Oh,
this.
I love when people,
Phenomenal.
yeah, I love when people visit my town and find a place to eat and they say it's one of the best ever. So absolutely, yeah, girl.
And just the whole
on
experience
that.
was so fun.
Yeah.
So yeah, there's my yeah girl. Okay,
Yeah,
what's
girl,
your
yeah, girl.
what's your my man? What do you got for us?
Yeah, absolutely. You know, there are so many things I could talk about, but I would like to talk about my wife, Jessica. We've only been married for a couple of years, and she's obviously the love of my life, and she's so beautiful and kind. But we are now entering the phase where we're going to try to have kids.
What? Oh
yeah,
my gosh, Dr.
so-
Valenson. That is so
Yeah, so-
exciting.
And I
love
told
it.
her about this podcast, and she already listened to one episode with me. And I think we're gonna have to become fans of your podcast because it's gonna be more relevant than ever. So
I am
that's
so
the-
happy for you.
that would
Obviously,
be my guy. Yeah.
this is my uterine fibroid. Fertility is my vasculature of the uterus. It is my
Yes.
absolute favorite thing. I love it when couples start opening up the door to trying. It is this is the reason I chose this field. It is the best thing in the world. I truly wish you guys the greatest blessings that this goes
Thank
so
you.
well,
Thank you
and
so much.
you have as many babies as your heart can hold. That is
Well, I
my
tell you
prayer for
what,
you.
there's a lot of incredible content on your podcast, so we're going to be
well,
tuning
thank
in
you.
and catching up. And it may not be a coincidence for me that ended up on your show at this time. So thank you so much
Well,
for
I
having
pray
us.
y'all
And
don't need me, but if you do, if something is happening and you're like, listen to an episode and you're like, I thought all these things I was doing were actually really helping me, and now I'm
Hey,
realizing
but
I am perhaps
nutrition,
needing a little more help.
food,
Then come on
information,
my way. I would love to
always
help you.
relevant. Yeah.
If
All
it
right.
just
thank you
needs
so
to be
much.
within the next 4 weeks. No, I'm just kidding.
Okay.
I'm about to go on maternity leave, but I'll come back after that. So,
All right.
okay.
All right.
Thank you so much, listener. Please rate, review, subscribe, share. It helps other people find us. It helps other women who are in tears right now, praying that there would be an option for their fibroids to be able to find this episode and see that there is hope beyond hysterectomy. So thank you, Dr. Valenson. Thank you, listener, and we'll catch you on the next episode.